Hello. So, good morning. I am Doc Franz and I'll be teaching you the therapy of non-bacterial infections. These are viral infections, fungal infections, and protozoal infections. So, let's start with the viruses. The understanding of how antiviral agents work is dependent on our knowledge of how these viruses replicate and infect the host. So, the general properties of how these viruses replicate and infect the host can be understood more easily by delineating which viruses contain DNA as their genome and which viruses contain RNA as their genome. So, examples of DNA viruses are pox viruses, herpes viruses, adenoviruses, hepadna viruses, and papilloma viruses. Pox viruses are very large viruses and they are very complex in their biology. Examples of um, poxviridae infections are infections with smallpox, a very deadly disease which has already been eradicated through vaccination. A relative of that is cowpox. Okay, and another relative of that still present right now but very benign is molluscum contagiosum, which causes a skin lesion. Herpes viruses are also very varied and it can manifest in many ways. So herpes simplex 1 causes the very common cold sore, and herpes simplex 2 causes vesicles and sores in the genitourinary tract. But herpes simplex 2 can also manifest in the oral mucosa. Okay? Herpes simplex 2 is a sexually transmitted disorder. Another common herpes infection is infection with varicella zoster virus, which causes chickenpox, generalized throughout all areas of the skin, and then later um, it will become latent in the nerves, and when the patient is immunocompromised or for other reasons such as fever from the nerves, it will reinfect a specific portion of the skin supplied by that nerve called the dermatome, and the lesions will be confined to the dermatome, so that general infection throughout the skin, very common in childhood, is what we call the chicken pox, and that dermatomal resurgence of the um, chickenpox virus or the zoster virus is what we call zoster, no, or shingles. Um, Next would be the adenoviruses, which commonly cause conjunctivitis or the pink or sore eyes. They cause cough and colds, and they can even cause pneumonia, no, in especially in children. Hepadna viruses cause hepatitis, and the genome is DNA. Kaya ang pangalan niya ay HEPA-DNA virus. An example of this would be hepatitis B viral infection. So hepatitis B viral infection is transmitted through blood contact or sexual contact. Hepatitis B infection can lead to fulminant hepatitis or acute hepatitis, no, which causes a short course of liver failure in a patient, no, infected with hepatitis B virus. The liver becomes so swollen and it leads to liver failure. Another manifestation of hepatitis B virus would be chronic hepatitis B viral infection, which leads to chronic inflammation of the liver, which leads to scarring of the liver, which leads to cirrhosis of the liver, which sometimes causes tumors to develop in the liver, and this leads to hepatocellular carcinoma or liver cancer. And therefore, since hepatitis B has a vaccine, hepatocellular carcinoma can be considered a vaccine-preventable cancer. Next is papilloma viral infections. So papillomas, these are finger-like tumors. Kaya siya papilloma. Oma means tumor and papilla means finger-like projection. So a very common presentation of papilloma virus infection is the wart, no? Yung kulugo. So this is caused by human papilloma virus. Yung kulugo or the wart can occur in the skin, and if it occurs in the skin, it is usually benign. But if it occurs in the anal region, the perianal skin, or inside the anus, or in the cervix, they are usually malignant. No? So cervical cancer, which is a sexually transmitted disorder, can occur later in life. So 40s, 50s, but the infection with papilloma virus occurred noon pa. Okay? And since we also have a vaccine for HPV, cervical cancer, and anal cancer is also considered a vaccine preventable cancer. Okay, so examples of RNA viruses are rubella, rhabdovirus, picornavirus, arenavirus, flavivirus, orthomyxovirus, paramyxovirus, coronavirus, and retrovirus. Rubella causes German measles. Rhabdovirus, an example of this would be infection with rabies virus. You have picoRNA. An example of these viruses would be polio virus, which causes paraplegia or paralysis of the lower limb. You have arenavirus, which is not very common here in our country, but in the United States, it causes hemorrhagic febrile illness. So may fever ang patient tapos bleeding from the orifices. Orthomyxo viruses and paramyxoviruses cause respiratory tract infections, viral respiratory tract infections, and even the mumps. Coronaviruses, no, cause the common colds and what we have right now, COVID, which is part of your reading. Under the paramyxoviruses would also be the measles virus. Okay, a childhood viral infection, measles. Okay, retroviruses are special RNA viruses because they have the enzyme that allows them to perform reverse transcription, where their RNA is back converted into DNA. An example of this would be HIV. So in this slide, you will see how DNA viruses replicate. First, they will have to enter the cell, and the first step for that is attachment. The viral particle attaches to a protein in the cell membrane, and this leads to endocytosis of the viral particle in what we call an endosome or vesicle. Inside that vesicle, the virus uncoats itself and releases its genome. So remember that a viral particle is composed of the genome, a protein capsid, and in some viruses, a lipid envelope. So in this step, while it is still in the vesicle, the capsid disintegrates and releases the nucleic material of the virus. This viral DNA enters the host cell's DNA, where it can be directly transcribed into viral messenger RNA, or it can be replicated, producing viral DNA. That step is called viral replication, and it is catalyzed by viral DNA polymerase. For DNA viruses, this can be a step upon which antiviral chemotherapy can be provided. So examples of drugs that inhibit this phase would be acyclovir, which is commonly used for herpes virus infections, vidarabine, foscarnet, and ganciclovir, which are commonly used for cytomegalovirus infections. The transcribed viral mRNA exits the host cell nucleus and goes into the host cell's cytoplasm, where it is processed by the host cell's ribosome to form structural proteins, viral enzymes, and regulatory proteins. So this step right here is how the viral infection hijacks the host cell's machinery. These proteins reassemble in a spontaneous pattern to form an immature virus, which then buds off from the host cell and is released into the periphery of that infected host cell to infect other cells. Okay, this is quite a bit more complicated, but this is how the RNA viruses commonly replicate. Special in this diagram is the replication of influenza virus. So your influenza virus at its surface contains heme agglutinin. This is a protein that allows the influenza virus to bind to the host cell surface. Upon binding to the host cell's glycoproteins, the entire virus is endocytosed and it forms an endosome, or technically just a vesicle. The viral protein, called M2 protein, allows protons or hydrogen ions to enter that vesicle. And inside that vesicle, it continuously becomes acidic. And that acidification allows uncoating and fusion of the viral capsid. So the viral capsid dissolves in that acidic medium, and that progressively releases the genome of the virus, which is in this case RNA. The viral RNA can be replicated through RNA replication, or it can undergo conversion into utilizable messenger RNA. So the viral RNA assembles into the immature virus, while the messenger RNA is processed by the host cell's ribosomes into structural proteins and non-structural proteins, which together with the viral RNA assembles to become the immature virion. So at this point, we have two classes of drugs that can be used for the therapy of influenza and RNA viruses. First is inhibitor of the uncoating M2 protein, which are amantadine and rimantadine, which can be used for severe influenza. Remember that amantadine, aside from its use in the chemotherapy of influenza infection, is also used for the treatment of Parkinson's disease because it increases the levels of dopamine inside the dopaminergic neuron. Ribavirin is an agent that is used for the treatment of respiratory syncytial virus, which is a common cause of viral pneumonia in infants. So, let us continue that immature virion or viral particle buds off from the host cell membrane by interaction with the host cell membrane's neuraminic acid, so that host cell membrane's neuraminic acid coats the immature virus to produce an enveloped virus. So that enveloped virus is already a mature virus. That interaction with neuraminic acid is facilitated by the viral enzyme neuraminidase, and this is where our anti-flu medications, zanamivir, oseltamivir, and peramivir act via the inhibition of neuraminic acid lysis. So, if you recall years ago when there was the pandemic of the avian influenza, our mainstay drug is oseltamivir, and this is where it acts. So let me focus our discussion right now on HIV. In this slide, you will see the pathogenesis of human immunodeficiency virus. Human immunodeficiency virus infection is a sexually transmitted infection. It is also transmitted via blood-to-blood contact, as in patients who septically use contaminated syringes when they use illicit drugs. This can also be seen in hospital workers, especially those handling needles, such as the medtech, the nurse, the RT, and the physician. So when they handle contaminated needles, in that needle is the blood of the patient or the fluid of the patient, and when they get pricked by that needle, they inadvertently inoculate themselves with HIV or the human immunodeficiency virus. Presented here in this slide is the pathogenesis as occurs in sexual transmission or contact with mucosal surface. So, the viral particles are present in the body fluids of the infected patient. So, this body fluid can either be in the form of urethral secretions, in the semen of men, in the vagina of women, and in the anus of both women and men. So, in the mucosa, this is what happens. The viruses from the fluids come in contact with the mucosa. This can be the urethra of men. This can be the vaginal epithelium of women, or the anus of men and women, depending on the sexual practice. The HIV enters or penetrates the mucosa, where it comes in contact with the submucosal layer, or that layer underneath the mucosa. Underneath the mucosa, you will find the lymphoid tissue that we call MALT, mucosa-associated lymphoid tissue. In the mucosa-associated lymphoid tissue, you will find two cells. The first cell to be infected by HIV are the antigen-presenting cells called dendritic cells. In these cells, viral replication is very rapid. And when the dendritic cells are immensely infected, they now start to infect CD4 positive T cells. So the dendritic cells and the antigen presenting cells in the mucosa become a reservoir for HIV. So HIV then concomitantly or consequently affects CD4 positive T lymphocytes. The CD4 positive T lymphocytes have in their cell membrane the protein CD4, which stands for cluster of differentiation 4, which we in the medical field stain to identify the particular T cell. So that particular T cell in the submucosa moves from the submucosa, so there is movement of that T cell through the lymphatic fluid. That moves to go and home into the lymph nodes or other lymphoid tissues. So in the lymph nodes, the infected CD4 positive T cell infects other T cells and macrophages in the lymph nodes. So the lymph nodes are what we call the Lusay in Bisaya or Kolani in Tagalog. So in that lymph node, you will see a lot of macrophages. You will see a lot of dendritic cells, and you will see a lot of T lymphocytes. The movement of the infected T cell there means that those cells will also become infected, so that the infection becomes established in that lymphoid tissue. So that lymphoid tissue or lymph node, together with the mucosa, become reservoirs for HIV, so that in the future, if the patient did become infected, and the HIV worsens and you give treatment for the HIV, you do not categorically eradicate the infection, because these reservoirs come into play. Even if there is no infection in the blood, there is infection in the reservoir when you treat them. Okay, and the HIV goes back to the blood because there is still HIV in the reservoir, the mucosa and the lymphoid tissue. Replication continues, and progressively it becomes much more effective, the viral replication in the lymphoid tissue, so that there is so high a number of HIV particles and they spill into the blood. Remember in your anatomy and physiology that the lymphoid tissue is in indirect contact with the blood through plasma, since lymph is technically the same with plasma, except for the presence of inflammatory cells and mediators. So the HIV goes into the blood, and in that stage, this is what we call viremia, or virus in the blood. During viremia, the host cell mounts an immense immune response, And this immune response is through antibodies and HIV specific cytotoxic T lymphocytes. So the antibodies coat the viruses and deactivate them or neutralize them. The cytotoxic T cells kill directly the infected cells so that spread and activity of the human immunodeficiency virus is halted. So, first there is viremia, and in this phase, the patient becomes initially symptomatic. So there is sexual contact. Let's just recap. There is sexual contact, there is infection of the mucosa, and then there is transmission to the lymph nodes, and there is continuous replication of the HIV, and it goes into the blood, causing viremia. The patient then becomes symptomatic with non-specific viral infection symptoms like fever, malaise, or the feeling of um, unsteadiness, no? Or there may be joint pains, there may be cough, okay? But once the immune response kicks in, the symptoms subside. So there is partial control of the viral replication. But what happens here is what we call clinical latency, where the virus infects CD4 positive T cells and macrophages, and those infected T cells and macrophages die. But the virus is still controlled because there is renewal of the T cells and the macrophages. So in this stage of clinical latency, we do not see any symptoms of immunodeficiency. But there is a balance between T cell death, an increase in the number of HIV particles, and then replenishment of the immune cells to counteract the HIV particles, so that the number of HIV particles in the body remains constant. But as with all other organ systems, with continuing function, replication, increase in the number of T cells, and then continuously killing of those T cells, there is exhaustion. And this exhaustion manifests 5 years to 8 years later. When the immune system is already exhausted, viral replication goes uncontrolled, and the number of HIV copies in the blood increase. And with this, there is now an imbalance, and the lymphocytes, their count, the number of lymphocytes decrease. And since you recall that lymphocytes are central to the coordination of the immune system, their decrease in number leads to impairment of the immune system. And this is what we call a syndrome of immunodeficiency. This is what we call acquired immunodeficiency syndrome, where there is destruction of lymphoid tissues and depletion of the CD4 positive T lymphocytes. So, in these patients, since the immune system is dysregulated and dysfunctional, they are prone to development of bacterial infections, fungal infections, and even cancers. So, example of a bacterial infection that heralds acquired immunodeficiency syndrome is tuberculosis. And this form of tuberculosis is disseminated, not only infecting the lungs, but also infecting the brain, infecting the kidneys, infecting the liver, infecting the bone. An example of a viral infection that heralds acquired immunodeficiency syndrome is infection with cytomegalovirus, and this may manifest as pneumonia, and you will see lesions in the lungs. You will also see CMV, cytomegalovirus retinitis, which may manifest in the patient as blindness. Or you will see herpes infection in the brain. Okay, what we call CMV or herpes encephalopathy or encephalitis. An example of an infection, a fungal infection that is common in AIDS patients would be infection with Pneumocystis jirovecii or Pneumocystis carinii. They are the same and they manifest as pneumonia. Okay. So please recall the pathogenesis of HIV as we discuss the drugs that we use to treat HIV. So this is quite familiar, and this is similar with the general scheme of replication of viruses. First, HIV has to attach to the cell surface of the T cell or the macrophage, and this attachment is due to the presence of CD4 receptors in the cell surface of the T cell and its interaction with glycoprotein 120. So GP120 is present in HIV, and what is present in the host cell is CD4. Okay. Not illustrated here is the important function of chemokine receptor 5 and chemokine receptor 4, which is also present in the host cell surface. So, upon attachment, the interaction of GP120 and CD4 receptors cause endocytosis of the HIV. Once endocytosed, the HIV uncoats, as explained in the previous slide, and the genome of the HIV, together with its active enzymes, is released or are released into the cytosol. In the cytosol, the enzyme HIV reverse transcriptase catalyzes the conversion of RNA from HIV into complementary DNA or viral DNA. So the process is called reverse transcription because normal transcription, if you recall, is the conversion of DNA into messenger RNA. But here, our template is RNA and we form DNA. Thus, we call it reverse transcription. And the enzyme that catalyzes that is HIV reverse transcriptase. The complementary DNA then enters the host cell's nucleus. So here we see viral DNA. That viral DNA inserts itself to the host cell's DNA through the process of integration, and the enzyme that catalyzes that step is HIV integrase. Once it has already inserted itself into the host cell DNA, central dogma occurs, and that DNA of the host cell, together with the DNA of the virus, is concomitantly transcribed to form viral RNA. Viral RNA at this step can be utilized in two ways. The viral RNA can become the viral RNA of the progeny virus, or that viral RNA can exit the nucleoplasm and be converted into proteins. So these proteins, initially through translation, are not yet mature. They are long proteins, and for them to become mature, we need to cleave some of these peptides to form mature, smaller viral proteins. And this step is catalyzed by HIV protease. So the mature viral proteins together with the viral RNA assemble to become the immature HIV viral particle. So that buds off and infects other cells. So through all of those steps, you will see numbers here 1, 2, 3, and 4. So these steps are inhibited by certain drugs for us to control infection with HIV. We can prevent the entry of HIV by blocking CD4 or by blocking chemokine receptor 5 and chemokine receptor 4. We have drugs for those. We can prevent the conversion of viral RNA to viral DNA by inhibiting HIV reverse transcriptase. The two classes of agents that do this are nucleoside reverse transcriptase inhibitors and non-nucleoside reverse transcriptase inhibitors. The two of them block the action of reverse transcriptase, but they differ in their chemical structure. The nucleoside reverse transcriptase inhibitors look like nucleotides. They look like adenine, guanine, cytosine, and thymidine, while the non-nucleoside reverse transcriptase inhibitors do not look like nucleotides. Example of this is efavirenz. Okay. We also have integrase inhibitors that prevent the incorporation of viral DNA into the host cell's DNA. So when there is no incorporation, the viral DNA cannot be transcribed. Protease inhibitors prevent the maturation of viral immature proteins so that they do not assemble to become mature viral progeny. An example of a protease inhibitor would be agents that end in navir. Examples would be sakinavir, lopinavir, indinavir. So these 4 steps are just these are the early discoveries, okay? But right now in clinical practice, we have multiple drugs with different mechanisms of action. So up to count, in our textbook, we have as much as 11 different mechanisms of action. Presented here are only 4. But suffice to say that because HIV takes up a lot of stages and phases, and these phases involve a lot of manipulations of the genome, HIV is prone to mutation. And in one patient, you can have multiple types of HIV because the initial HIV particle that has entered the patient has already mutated, and therefore in that one patient you can have many forms of HIV, and this mutation can lead to multiple drug resistance. And that is why when we treat HIV, we utilize a combination of agents with differing mechanisms of action. These differing mechanisms of action cause synergy in their effect in the treatment of HIV. This synergy allows the clinician to decrease the dose of each agent used. And when we decrease the dose, we also preclude the occurrence of adverse effects and side effects. So that is beneficial for the patient. It improves efficacy and decreases the occurrence of unwanted effects. So this practice is what we call highly active antiretroviral therapy. So the principle here is to utilize agents with different mechanisms of action. And if the resistance patterns for that patient is very severe and very hard to treat, we can utilize as much as 7 or 8 agents, all each targeting different phases of the HIV replication cycle and with each differing in mechanism of action. So the baseline combinations would be one nucleoside reverse transcriptase inhibitor plus one non-nucleoside reverse transcriptase inhibitor plus one protease inhibitor. Or if there are untoward effects of that combination, we can utilize two different nucleoside reverse transcriptase inhibitors and one non-nucleoside reverse transcriptase inhibitor. But technically, we can utilize many agents, depending on the response of the patient to the initial therapy. So, because the mechanism of immune dysfunction in the patient is due to death of the lymphocytes and macrophages due to HIV, theoretically, if we control HIV replication and we limit the number of HIV particles, we can improve immunity in the patient. So this immune reconstitution results from effective chemotherapy of HIV. So this immune reconstitution may manifest in the patient as improvement in infection. So for example, if the patient comes in with severe tuberculosis because the immunity is down due to AIDS, if we treat the HIV infection with highly active antiretroviral therapy, the immune system of that patient goes up, and the immune system then handles the tuberculosis, and we see a clinical improvement in the tuberculosis of the patient. Okay? But that process can also become dysregulated. So, initially, with AIDS, the patient is immunocompromised. Once we give the antiretroviral therapy, there can be an entity we call immune reconstitution inflammatory syndrome, or IRIS. And this is a hyperimmune state where the body destroys its normal tissues. So in an AIDS patient, we can be faced with a lot of things. We need to treat the AIDS, we need to treat the HIV infection, number one. Number two, we need to treat the infection with other pathogens. For example, infection with fungi, infection with bacteria, infection with other viruses. We need to treat those also. In some patients, they develop malignancy because the immune system also handles the killing of malignant cells. So AIDS patients may have malignancies. We also need to treat those. And lastly, another problem that we might encounter is IRIS, where the immune system destroys normal host tissues. And this might be deadly for the patient. So we also need to treat that. Now let's proceed to chemotherapy of fungi. First, fungus is a eukaryotic organism. It means that its nucleus is somewhat like that of an animal's. So we have the concept in chemotherapy of infections called selective toxicity. I hope this was already explained to you. Selective toxicity means I want to kill only the pathogen and spare the host. So that is important because if we want to treat the infection, we don't want to endanger the host. But that selective toxicity is primarily due to differences in the structure of the host and the pathogen. But in fungi, we recall that these cells are also eukaryotic. Therefore, they are more similar to the host cell than, let's say, a bacterium. A bacterium is entirely different because it's prokaryotic. Its structures are different. Therefore, when we target those structures with chemotherapy, we can effectively treat them, and they are sufficiently different than the host that we do not affect the host as much. But if you surmise, even the treatment of bacterial infections carries with it side effects and adverse effects, how much more if the pathogen that we are dealing with is structurally and genetically similar with the host? So in antifungal chemotherapy, we expect at the least much more interactions than chemotherapy of bacterial infections. Okay, so structurally, the fungi that we deal with, the medically important ones, can be a yeast or a mold. A yeast is unicellular and a mold is multicellular. So the image in your left tells you of the morphology of the yeasts and the molds. Um, on the yeast portion, you can see how they divide. And on the mold portion, what you see under the microscope, you can have separated nuclei in septate hyphae or a conjoint nuclei as in sinusitic hyphae. Okay, so that is important because the medically relevant fungal infections come in those two forms. Okay, so a clinical approach to fungal infections would be to separate them based on how they infect the body. So we can be dealing with a superficial mycosis, which infects only the skin, the hair, the nails, and the mucosa. Or we can be dealing with a deep mycosis, which affects the subcutaneous tissue, which means the fat underneath the skin, or the organs of the body, or the blood itself. So, clinically, we differentiate the many forms of mycosis. When we say mycosis, myco means fungus and osis means disease, so a fungal disease. We can be dealing with superficial and deep ones. There is such a category as dimorphic fungi, and the dimorphic fungi exist in nature as a mold, as spores, but once they enter the body and they encounter the warm environment of the body, they transform into a yeast. So they have two forms. They are dimorphic. These dimorphic organisms specifically cause systemic fungal infections. So let me highlight histoplasma. Histoplasma or histoplasmosis is the disease, and it is caused by Histoplasma capsulatum. Histoplasma capsulatum is a pathogen that is usually seen in the dung of bats. So most patients that we see with Histoplasma capsulatum infection would be those patients who have a history of spelunking or going and swimming in the caves where there are bats. So, as with all other dimorphic fungi, the common mode of transmission would be inhalation of the spores of the fungus, and then the spores enter the respiratory tract, and once they reach the terminal portions of the respiratory tract, they transform into molds, and the molds would stay there, and you'd have like a fungus ball in there, and they spew out into the blood in the form of yeasts. So let me now focus the discussion into candidiasis. So I'd like to discuss candida because it can cause superficial mycosis and can also cause deep mycosis. So the superficial mycosis, you will note in areas that are moist and warm, such as around the groin, around the vulva in females, the perineum in males, and around the perianal region. So those are moist, and they are warm, and candida likes to live there. So once the skin is infected with candida, it will manifest as extremely red skin. There is extreme pruritus or itchiness, and it is painful. And once you look more closer, more closely, you will see satellites of white. These are microsatellites of candida. So that's very itchy. Candidiasis is also what causes diaper rash in pediatric patients, the infants who wear diapers. When the diapers get fully soaked, that wetness together with the warm region predisposes the infant to candidal infections. Candidal infections can also be seen in the mouth. So this is what we see as oral thrush. So most patients that have oral thrush are those that utilize inspired or inhaled corticosteroids for the treatment of asthma. So remember the powdered dose inhaler and the meter dose inhaler. When the patient aspirates the steroidal powder, some of the steroids can be left in the mouth. And if they do not rinse off and gargle that steroid continuously impairs immunity in the mouth, the mucosa there, and candida overgrows. And you will see whitish lesions that are quite painful. So that's oral thrush. Okay, so when you are in your boticas in the future, please counsel the patients who are prescribed meter dose inhalers for asthma to always gargle and wash adequately after they take the powder, okay, or brush their teeth. Okay, so that's for the superficial manifestations of candida. But candida is notorious in the hospitals in causing candida bloodstream infections. So candida bloodstream infections, or candida BSI, is also known as candidemia. When you see the word emia at the end of another word, it means you are seeing that entity in the blood. Okay. So, as with all other infections, there has to be some sort of dysfunction with immunity so that the colonization of these pathogens can become more prolific and they cause infections. So, the high-risk populations would be those that have hematologic malignancy, so cancer of the blood. In cancers of the blood, we usually see dysfunctional white blood cells that fill the entire blood. And in the bone marrows, we see immature white blood cells. And since they are still immature, their function in controlling infection is quite poor. So next would be in neutropenia. Neutropenia means low levels of neutrophils in the blood. These low levels of neutrophils in the blood may be due to drugs that we take. For example, we can have neutropenia in the intake of some antithyroid medications. We can have neutropenia from agents that are used in chemotherapy. Okay. Gastrointestinal surgery is quite a stressful process for the body. Because of that extreme stress in the body, the response would be to release cortisol from the adrenal gland. So that cortisol from the adrenal gland circulates in the body and impairs immunity. So remember that corticosteroids are anti-inflammatory medications. And therefore, in gastrointestinal surgery, where there is a lot of cortisol in the body then becomes anti-inflammatory. And an adverse effect of having an anti-inflammatory nature would be the inability to ward off infection, in this case candida. And lastly, extremes of age. When the patient is extremely young, the immune system is immature, and when the patient is extremely old, the immune system is quite tired already. So they can either have no candida infections or they can have candida infections. So candida resides commonly in the hospital. Why? Because the patients in the hospital, especially in the intensive care unit, are battling diseases that are quite stressful and they have impaired immunity. In the hospital and even in the community, when the doctors prescribe antibiotics, the effect on microflora, which is the normal residing microorganisms in the body, is quite extensive. So the microflora is made up of a combination of commensals that are bacterial in origin or fungal in origin, and they coexist. They are most common in the gastrointestinal tract, particularly in the colon. So when the microflora is exposed to antibacterial antibiotics, majority of the susceptible microflora that are bacteria die, and therefore the spaces and the nutrients that they usually occupy and use become available for all the other surviving organisms in the microflora. And one organism is Candida. Candida is a microflora of the body. And Candida, because it does not have any competition, now grows. And this is what we call a superinfection. The Candida grows, and they may grow to such an extent that they spew out into the blood, and this will lead to candidemia. The use of central catheters is employed when we want to give high volume of fluids and certain drugs into the patient. So we usually utilize the big veins and even arteries of the neck and the shoulder. So because we create a wound and introduce a foreign material into those vessels, if the foreign material is contaminated with candida, we are directly introducing candida. And since candida is a microflora of the skin also, and because there is an insult into the skin as a barrier, we are also directly introducing candida into the blood. Furthermore, the catheters and the tubes that we use for hemodialysis The catheters and the tubes that we use for hemodialysis do not contain white blood cells. Okay? And therefore, our immune system cannot go into this foreign material and mount an immune response against Candida. Lastly, the use of antibacterial agents in the ICU and merely the extent of disease of these patients in the ICU, we consider them as patients who have a high risk for antimicrobial resistance because there is polypharmacy. Ibig sabihin, they use a lot of agents at the same time. They are immunocompromised, and the ICU itself is, even if it is regularly cleaned, and the hospital pays a lot of attention to cleaning the ICU itself is quite prolific in its number of AMR, antimicrobial resistant pathogens. So these exposures, together with the risks in some patients, lead to infection of Candida, particularly in the blood. And this is what we call Candida bloodstream infection or candidemia. So this pie graph shows that out of 100 patients with infection of Candida in the blood, half of them will die because of that. 12 of them will die because of the risk factors that led to candidiasis, and only 39 of them will survive. So this is the reason why I emphasized candidal infections for this topic, because it is such a big burden. Now, this slide shows you how antifungal medications work. On the left side of the image, you will see the pathway for the synthesis of ergosterol. Ergosterol is the fungal counterpart of cholesterol, and it maintains the properties of the fungal cell membrane. So ergosterol is synthesized from squalene, and if you recall the synthesis of cholesterol, squalene is basically a polymer of acetyl coenzyme A. Squalene is oxidized to form squalene epoxide, and this process is catalyzed by the enzyme squalene epoxidase. Squalene epoxide is converted into lanosterol by the enzyme cyclase, and lanosterol is converted to ergosterol, which is the functional fungal sterol in the cell membrane of fungi, via the enzyme lanosterol 14-alpha demethylase. So this tells you that the final step in the formation of ergosterol would be the removal of methyl group from lanosterol. So in this pathway, we have two classes of drugs. First would be drugs that act earlier in the pathway, and these drugs inhibit squalene epoxidase. These drugs are termed allylamines, and this terminology is based on the chemical structure of these drugs. You have an allyl and an amine. Examples of this would be terbinafine and naftifine. Terbinafine is utilized in chronic infections of the nails. The nails are really hard to treat because they grow slowly. And when you have a fungal infection there, you may need to provide an agent that is very lipid soluble, and terbinafine is quite appropriate for that. Okay. Another class of drugs that act on the final step for the formation of ergosterol would be the azoles. And the azoles inhibit lanosterol 14-alpha demethylase, which catalyzes the removal of the methyl group from the alpha group of lanosterol. So the azoles are CYP inhibitors. So they inhibit the oxidation that is required for the oxidative demethylation of this step. So imidazoles and triazoles are subcategories of azoles. The triazoles are more advanced agents, and the imidazoles are the primordial azoles. Okay, examples of these agents would be the ones that you see in the market, ketoconazole for skin infections, clotrimazole for skin and mucosal infections, and miconazole for mucosal infections. Okay, we can also target the cell membrane of these fungi by the utilization of polyenes. So polyenes create holes in the cell membrane of these fungi, and when the holes are present, extracellular fluid will then enter the inside of the fungal cell, and this creates an increase in turgor in that fungal cell, which ultimately leads to fungal cell lysis. So these agents are fungicidal, whereas the azoles are fungistatic. So similarly, in our treatment of fungal infections, if there is immunocompromise that is severe, we usually want to go with fungicidal agents. And if the immunity is intact still, we can utilize the fungistatic agents. So another class of antifungal agents would be those that act on the genome of the fungus. So an example of this would be the antimetabolite flucytosine. Flucytosine is given to the patient usually intravenously, and the flucytosine circulates in the blood of the patient and goes into the liver of the patient, where in the liver the flucytosine is converted into 5-fluorouracil. 5-fluorouracil, if you recall, is an anti-cancer metabolite. So the 5-fluorouracil, just like in the treatment of cancer, integrates into the fungal genome and prevents transcription of the fungal genome. Okay, so flucytosine, if you will see in the prescriptions in the pharmacy, especially in the hospital pharmacy, is usually in combination with amphotericin B. That creates a synergistic effect. Amphotericin B creates holes in the cell membrane, and 5-fluorouracil will then be able to effectively enter the cell membrane to inhibit fungal nucleic acid synthesis. So another agent that I'd like to emphasize is griseofulvin. Griseofulvin is extremely lipophilic, and therefore its absorption is increased with the intake of a fatty meal. So if you see this prescription, please counsel your physician or your patient to give this drug with a fatty meal. So griseofulvin is an inhibitor of fungal replication. So remember that in cytokinesis, the last step of cellular division, that movement of the cell membrane is catalyzed by the movement of microtubules. And so griseofulvin acts in such a way that this movement and assembly and disassembly of the microtubules is inhibited, so that there is no movement of the cell membrane. The cell as a whole will not divide, and its cellular components will not be able to exert their effect. Lastly, which is very expensive and specific for the treatment of candidal infections, would be the echinocandins. So the echinocandins are specifically prescribed for candidemia, which is highly deadly for our ICU patients. So echinocandins are very expensive. And when you handle these drugs, please be very careful not to drop or to break the vial, because that is around 60 to 70,000. So, echinocandins inhibit the polymerization of glucans and chitin. If you remember your biochemistry, glucans are polymers that are made up of glucose, and chitin is a sulfated hexosamine. So that means that in chitin you will see a 6 carbon sugar, a nitrogen group attached to it in the nitro form, and a sulfur group attached to the nitro group. So these molecules polymerize to form the fungal cell wall, and echinocandins inhibit the polymerization of those molecules and therefore inhibit the synthesis of the fungal cell wall. Much like in bacteria, where we inhibit the polymerization of murine, okay, through cell wall synthesis inhibitors. So lastly, let's discuss protozoal infections. Similarly, protozoans are eukaryotic, and therefore our concept of selective toxicity is placed into question. And therefore, when we use antiprotozoal agents, we must expect that the frequency of adverse effects would be much higher than when we use antibacterial agents. So I'd like to focus our discussion on amoebiasis. So amoebiasis is the infection caused by Entamoeba histolytica. And Entamoeba histolytica is a protozoan that is usually transmitted via the fecal-oral route, which means an infected patient poops, and the poop contaminates drinking water or the food that is handled. So Entamoeba histolytica enters the gastrointestinal tract of the patient which is to be infected, and it releases proteases and glycosidases that degrade immunoglobulin A and mucin. So remember that immunoglobulin A is present in secretions, and it is important for immunity in our mucosal surfaces. So included in the protection is prevention of infection with Entamoeba histolytica. But because E. histolytica has these enzymes that degrade immunoglobulin A, they survive and are able to enter the interior of the enterocyte, or the cell of the small intestine. So they are also able to enter the cell of the colon, or the colonocyte. So once inside the cell, they block the activity of our immune cells, such as the neutrophils, the complement pathway. They block that. So they are able to evade destruction by these media. The Entamoeba histolytica survives, and it now will be able to access the blood of the patient by degrading the blood vessel. Once it has access to the blood of the patient, it takes in for food the red blood cells. They degrade the red blood cells and eat the hemoglobin inside. The iron gives them a cofactor for their metabolism, and the globin portion of the hemoglobin serves as their energy source. So that is how Entamoeba histolytica causes disease. The manifestations of this would be dysentery. So dysentery is basically a fancy term that we use for very painful diarrhea that is bloody, very painful bloody diarrhea. And you will understand why it is bloody, because Entamoeba histolytica has to access blood for its food. So Entamoeba histolytica is a very common cause of dysentery. So much so that when doctors encounter dysentery in their clinics, they will automatically think of this one and prescribe metronidazole. So Um, Entamoeba histolytica will burrow into the colon, and it will create ulcers in the colon, and it will also burrow itself into the intestines and create ulcers there. But what is special about amoebiasis is that if there is already bloody diarrhea, we should think that there is access to the blood vessels, and that this Entamoeba histolytica will be able to traverse the bloodstream and cause abscesses or mga nana that is surrounded by a capsule. So these abscesses may be found in the liver, and this is what we call an amoebic liver abscess, or it may be found anywhere in the body, in the lungs and in the brain. So in the brain, it is already very deadly. And lastly, how do we treat protozoal infections? So in this slide, you will see the different antiprotozoal agents that we have. These antiprotozoal agents can be cross-utilized, which means if you're going to treat amoebiasis, you can utilize the agents that are even used to treat malaria, and it can be the other way around. The antimalarial agents can be supplemented with anti-amoebic agents and so forth. So let us first discuss ivermectin. Ivermectin activates the chloride channel, and when chloride enters the cell, okay, the amoebic cell or the protozoal cell, it will cause water to go in together with sodium, and that sodium and that water that goes in will then cause lysis of the cell due to turgor. Praziquantel increases calcium intracellularly, and calcium, if not handled by the cell appropriately, is cytotoxic. It will cause death of that cell. So our body is so special that it will always handle calcium and cause calcium to have lower levels inside the cell. The protozoal cell is not as effective as our cell, and so this creates a form of selective toxicity. Artesunate is an agent that we use for malaria. Praziquantel is an agent that we use for the multicellular protozoans like worms, okay, the flatworms particularly. Ivermectin is an agent that we use for the blood protozoans. Okay. Paromomycin binds 30S, the 30S ribosome, much like the antibacterial protein synthesis inhibitors. Okay. Most antimalarials will inhibit DNA synthesis, and so you will see in the chemotherapy of malaria that most of these agents inhibit the metabolism of folate, so that there is no interconversion of thymine, uracil, and cytosine, and therefore the cell won't be able to perform DNA replication and DNA transcription. Primaquine is our radical agent for the treatment of malaria, which means it treats malaria in the blood and malaria in the liver. Remember that in malaria, the liver can become a reservoir for reinfection. So you may be able to clear the blood, but later on, malaria will then re-enter the blood from the liver. So primaquine is special because it kills the two of them, malaria in the liver and malaria in the blood. For our special purpose in the treatment of amoebiasis, we use the two agents, metronidazole and nitazoxanide, which inhibit iron-catalyzed energy production in our amoebic cells. So this iron-catalyzed energy production is through pyruvate ferredoxin oxidoreductase. So Um, Remember that in the last step of glycolysis, the pyruvate that is formed is converted into acetyl coenzyme A via pyruvate dehydrogenase. The amoebic isoform of that pyruvate dehydrogenase is P4, pyruvate ferredoxin oxidoreductase. So that's how the um, the amoebic cells gather their energy. If we inhibit that, these cells do not form ATP and they die. Benzimidazoles, okay, these are used for both malaria um, and amoebiasis and extraintestinal multicellular protozoans like the worms. Example of that would be albendazole, and it disrupts cytoplasmic, microtubule, and glucose uptake. So if the microtubule is inhibited, cellular function ceases, the cell won't be able to divide, and its organelles won't be able to translocate within the cell. And it also prevents glucose uptake, which means that the worms become hypoglycemic and they become highly irritable and they die. So, lastly, permethrin, which we use as cabicide, no? Ibig sabihin yung ectoparasite that lives in the skin and hair, no? Inhibits sodium influx, and without depolarization of some neural tissue and some muscle tissue of these ectoparasites, they die. So that in toto is the mechanism of action for your anti-protozoal agents. So let's just recap before we end that today we discussed how viruses replicate, how HIV causes disease, and how we treat HIV. We also discussed some special features of fungi and how the antifungals work in the different biologies of these fungi. And lastly, how amoebiasis creates disease, which is dysentery, painful bloody diarrhea, and how we can use agents that are originally used for malaria, for worms, and for the treatment of amoebiasis and intestinal protozoal infections cross therapeutically, which means we can utilize these agents for other purposes. So with that, thank you and good luck for your prelim exams. If you have difficulty accessing this lecture or taking the exam because of the recent typhoons, please contact our dean. Thank you.